Now may I invite our Deputy Director for Innovations and Partnerships, Dr. Philip Matthew, sir, to welcome our speaker and introduce her. We have a very special speaker today. Research has been one of our core areas of interest, and this year also we have resolved to do a maximum research and come up with path-breaking articles, as our director said. So today we have a brilliant researcher in our midst, and may I request Philip sir to introduce her.
Good morning all. I'm just quoting something from the Bible. St. John chapter 1 verse 46. Nazareth, exclaimed Nathanael, can anything good come from Nazareth? Come and see for yourself. Philip replied. Today I'm happy to introduce Rinta Susan Matthew. Why I took this quote is, she is from a small village called Ennakad, which is near Chenganur. And here is a path-breaking innovation or a research that is going to change. We all know there is no particular treatment for pancreatitis. And the world has recognized an innovation from this small town near Tiruvalla. And today we are here to listen from Rinta the journey of Sprotone and her journey at the University of Manchester. She did a MSc Zoology and MPhil Zoology from Loyola, Chennai. She was a rank holder, first rank holder there. And from there she went on, she took that initiative to call out to the University of Manchester, and they were extremely interested with what she wanted to do, and they called her in, and she bagged a scholarship of 1.75 crore for the next 2 years. It's a doctoral scholarship. It's something that as doctors we don't look into something into this depth into research, but it's really encouraging to see something happening from a nearby town, and I welcome Rinta to enlighten us about her journey and the journey of Sprotone.
Thank you, Dr. Philip, for that wonderful introduction. I think you forgot to mention that you are also from Ennakad. So good morning, everyone. So my title today is Sprotone, a promising supplement to treat acute pancreatitis and diabetes. So introduction. Acute pancreatitis, as you all know, is a serious and sometimes an inflammatory disease, which is fatal, caused by autodigestion, resulting in pancreatic necrosis, systemic inflammation, and in severe cases causing multiple organ failure. So mostly it results in about 1,000 deaths a year in England and costs UK around 200 million pounds, and in the US it costs up to 2.6. So in severe cases the mortality rate increases, and also the patients are admitted in hospitals for prolonged periods. So like Dr. Philip already mentioned, right now there are no targeted and effective treatments for acute pancreatitis, which leads into Sprotone. So my supervisory team includes Dr. Jason Bruce. He's my primary supervisor. So he is the first one who actually proved the first mechanistic link between diabetes and acute pancreatitis. So he works on animal models which is genetically altered, which is called Paserico mice, where in the mice the insulin receptors are abolished. So it's like a knockout of insulin receptors. And my co-supervisors includes Dr. Joe Pennock and Dr. Ian Roberts. So they are also immunologists. We have an angle to our research which includes gut microbiome. So when it comes to that angle, we will be meeting with Joe and Ian to start that kind of work. So the link between diabetes and pancreatitis. So as you all know, pancreatitis, it causes pancreatic injury, which is mainly to the ice in our cells. But as a collateral damage, there is beta cell damage, which results in impaired insulin secretion, leading to diabetes. But there is a new clinical and animal studies which shows that diabetes in turn increases the severity of pancreatitis, and by causing hyperlipidemia, inflammation, and sepsis. So what happens is that insulin has a direct protective effect for acute pancreatitis. So insulin protects acute pancreatitis by preserving the ATP and also by reducing the calcium overload, so which in turn prevents the ACE cell injury. But when it comes to diabetes, there is already a decrease in the insulin secretion, which directly leads to ACE cell injury and in turn increases the severity of acute pancreatitis. So Dr. Bruce, he was the first one to show that insulin has a direct protective effect to acute pancreatitis. So how insulin directly protects pancreatitis is by preventing the calcium overload, by preventing ATP depletion, and also by preventing necrosis. So the molecular mechanism by which all the three process is been protected is by the AKT-mediated phosphorylation of PFK-FB2. So in the glycolytic pathway, there is a key glycolytic enzyme called PFK-FB2, which is phosphofructokinase, fructose bisphosphate 2. So what happens is that the AKT gets phosphorylated, which in turn leads to the phosphorylation of PFK-FB2 in the glycolytic pathway, leading to the production of ATP. So what happens in acute pancreatitis is, despite a number of causative factors like alcoholism, bile acid reflux, hyperglycemia, what happens is that there is an increase in calcium overload and in depletion of ATP because of impaired mitochondrial metabolism. So what we want is, we want ATP to be produced in order to preserve the ATP and also to transport the calcium from the cytosol towards the outside of the cell. So what happens is that when in the presence of insulin, the AKT-mediated phosphorylation happens and a glycolytic ATP is produced. Rather than from the mitochondria, the glycolytic ATP is produced, which in turn activates the PMCA pathway, transporting the calcium from the cytosol towards the outside. So it's a calcium channels which helps in transporting the calcium outside. So how insulin works is by protecting the ATP production through glycolysis. So that's how it says insulin increases the glycolytic energy supply during pancreatitis. So this is a process in which insulin prevents pancreatic ACE cell injury during acute pancreatitis. So what I have working on is on the product called Sprotone. It was developed by my father based on Ayurveda literature. Sprotone is a functional food formulated from sprouted cereals and pulses, where multigrains such as wheat, ragi, horse gram, green gram, fenugreek are soaked and sprouted in water for up to 48 hours, and flaxseed is also an ingredient. So during my time in India, like Dr. Philip said, I was working in Sprotone in my master's and in my MPhil. So during my master's, I worked on cell lines, which is rat myotubes, because in the maximum glucose uptake, as you all know, takes place mostly in the skeletal muscles. So I wanted to see if it has any insulin mimetic action. So I worked on the intrinsic pathway of P38-MAPK. So I found out that it in turn activates the MAPK and transports the GLUT4 transportation happens, which in turn helps in the translocation. So what I did was, I did a glucose uptake assay and I did the P38-MAPK phosphorylation, and I found that Sprotone stimulates that intrinsic pathway and helps in increasing the glucose uptake, thereby reducing the blood sugar levels in blood. We also did an animal study in Amala Cancer Research Center, Thrissur, where the animals were induced with streptozotocin and made diabetic, and then it was treated with Sprotone for a period of a month, and the control was the metformin, and it was found that Sprotone shows equivalent and comparable results to that of metformin. So it was with these results that I approached Dr. Jason Bruce, proposing that it might, since it has already an insulin mimetic action, it might have an effect in acute pancreatitis. Because as you all know, insulin cannot be used for a treatment for acute pancreatitis because it causes severe ketoacidosis. So it can never be taken in as a treatment protocol. So we need something which will mimic insulin, but at the same time won't cause any other problems. So I'm in my first year, I just finished my first year. So our hypothesis was Sprotone exhibit insulin mimetic effects, reduces the severity of acute pancreatitis by directly protecting the ACE cells. And since it was my first year, I was working on cellular models. So the specific aims was we needed a method of extraction which was effective. We needed to find that the particular concentration of Sprotone, which doesn't have any effect on the resting calcium levels, because Sprotone shouldn't increase calcium levels on its own. And then we needed to prove that insulin, Sprotone reduces the calcium overload and reduces the ATP depletion, and also if it has a phosphorylative effect on the glycolytic enzyme. So these were the aims for my first year. So we figured out the Sprotone extraction with ethanol, which was found to be the most effective method. And then I had to experimentally prove the cell isolation protocol. We had imaging experiments for calcium overload testing. Cellular ATP was measured, and then it was finally Western blotting. So like I said, we needed to figure out the concentration which made sure that there was no calcium response caused by Sprotone. So we tested 3 concentrations, which was 0.3% Sprotone, 0.1 and 0.03%. So you can see in the first 2 images, Sprotone on its own is causing an irreversible increase in calcium. So those concentrations cannot be used. And when it comes to the third concentration, you can see that for the time where the Sprotone is treated, there is no calcium response. So we went ahead with carrying out experiments using the 0.03% Sprotone. So POA, as you all know, is an ethanol metabolite. So there was previous experiments run by Dr. Jason Bruce testing out which is the most cytotoxic agent for acute pancreatitis. So ethanol, POA, etc. were tested, and POA was considered the most cytotoxic for acute pancreatitis. So it was like a bona fide agent for causing acute pancreatitis. So that's why I worked with POA. It's called palmitoic acid. So again, the concentrations of 30 and 100 were already standardized by Dr. Jason Bruce. And so on average, you can see the 30 micromolar POA increase the calcium by 244 nanomolars. So what we do is we expose the cells to POA for the first 10 minutes, and then we wash out. And then again, we are adding CCH, which is like cholecystokinin. So this has been added to see if the cells remain viable throughout the entire process. So once the CCH is added, you have to see some kind of a variation in the graph so that you know the cells are viable after a period of like 30-40 minutes. So our POA alone caused calcium increase of 244, and then what we do next is we first treat the cells with Sprotone for the first 30 minutes, and then you add the POA again, and then you wash out and you add CCH. So it reduces the calcium intake calcium levels to 20 nanomolars in the presence of 0.03%. So what insulin does in the same protocol is that with 30 it increases up to, it depends on the cell lines and how the process of cell isolation is done. So what happens with POA in the case of insulin is from 600 nanomolars, insulin brings it down to 100. But you can see in the case of Sprotone, from 244 it was brought down to 20. And so the results were also similar in the case of 100 micromolars, where the calcium levels were increased up to 784, and it was brought down to 639 by Sprotone. Again, when it comes to ATP depletion, so I have been working on the same exact protocol as with insulin, but the difference was that instead of using insulin, I'm using Sprotone. So the 30 micromolar caused the 52% ATP depletion. So again, it's the first 10-minute treatment with 30 micromolar POA, and then you have an ATP depletion cocktail, which brings down the ATP levels to very low amounts. So you first add POA for 10 minutes, which brought down the ATP depletion to 52%. And the next experiment is where you treat the Sprotone for 30 minutes, and then you add the 30 micromolar POA, and it was only 11% ATP depletion. Again, with 100 POA, it caused 73% ATP depletion, but after the pre-treatment of Sprotone, it was brought down to 29%. So like I said earlier, insulin causes the AKT-mediated phosphorylation of PFKFB2. So my next step was to see if like insulin, Sprotone will also have the same reaction. So I did Western blotting with all the three concentrations of Sprotone of 0.3%, 0.1% and 0.03%. And Sprotone treatment induce a phosphorylation of AKT. You can see in the first image, the last three concentrations, it's a 0.3%, 0.1% and 0.03% are dark and you get a band there. And also in the second one, in the 5 minutes range, that's insulin. So like insulin, so the second one is the band for insulin and the last three are the bands for Sprotone. Again, when it comes to PFK, FB2, you get bands in the second one and also the last three one. Here the control is also showing. So we have quantified how much the intensity of each band is. And the bands where the intensity was similar or greater levels to insulin. So in summary, what I'm trying to prove is the same exact protection, but instead of insulin, I'm trying to see if Sprotone has the same exact reactions to Sprotone. So I've just finished with my cellular models and hopefully it'll go in the good way and I'll be able to prove that Sprotone also preserves the ATP, reduces the calcium overload and prevents the ACNR cell injury. So my future step is we have a couple of more experiments with cellular models. So I have to finish all of those where we calculate the cell death and autofluorescence of NADH. And we are planning to identify the components of Sprotone because as already mentioned, we don't have a specific drug or an effective treatment for acute pancreatitis. So if we can figure out one particular component or a molecule in Sprotone which shows the activities of insulin, it can later be developed into a drug. So I am right now working on extracting Sprotone, filtering it and finding out the molecule that gives the correct effect. So it is to identify all components of Sprotone and then I will have to do the same cellular assays with that molecule alone rather than with the whole Sprotone extract. And then I have to go into in vivo models. Like I said earlier, I'll be working with acute mice, which is a diabetic mice, and then the Pesarco mice where the insulin receptor has been abolished. So I can for surely say there is no insulin presence in those models. And then I'll have to again test compare the results of the identified molecule, if I get any, with the Sprotone extract in vivo models. So these are my future steps and I hopefully will be able to complete my PhD in 3 years. Thank you everyone. Do you have any questions?
Thank you very much. My name is Philip. I work in endocrinology. My question is, you showed me that packet. If you can show me the slide of that Ayurvedic mixture, that packet which you showed, no?
Yeah, the first one.
The first one, yeah. So Sprotone is a combination of many different items, yes. Correct? And so the challenge for us is all of these will have various active ingredients which may probably doing the effect. And how do you delineate that? Many years ago, I did a study on jasmine flower extract, which women use here to suppress lactation. And when we tried to prove in a study to reduce prolactin, the biggest challenge we faced is identify which is the active ingredient. So how are you going to delineate that? Can you separately going to test it? What are your plans? I was just trying to figure that out.
So that's exactly a challenge that we are also facing right now. We are talking with people in the university. So we are planning to do HPLC and mass spec to identify what are the components. So right now what we are doing is we are using molecular filters of different molecular weight and testing each fraction and figuring out which fraction shows the maximum effect. And then testing that fraction alone for mass spec and HPLC. So we get different graphs and we obviously will have previous literature to see so there is already a study where galactose shows a similar effect in case of diabetes. So there is Sprotone already has galactose. We could go in that way and find out that which form of galactose or which form of isoform. So that's what we are planning to do right now. It's a long process. I'm not promising anything, but yeah, right now we are doing that. Hopefully I answered your question.
Yeah, this molecule, this are a natural food, which is probably is unrefined, isn't it? So probably this a lot of studies are going on regarding the restoration of the gut bacteria, which may be signaling. Ultimately, your research is going in the direction where the gut bacteria, restoration of the gut bacteria, because that if restoration of the gut bacteria take place, the reversal of the many of the illness reverses. That's one of the signaling the diabetics and other things in pancreatitis, that injuries. Probably that you should gut microbiota. What are the type microbiota increased following this introduction of this unrefined food? This actually the real, I think my assumption is probably the gut microbiota is actually playing indirectly.
So I forgot to include it because it was not part of the link. So in my master's I did work on gut microbiome. So there was a study which shows that lactobacillus and bifidobacterium levels are reduced in diabetic patients. So I had used Sprotone extract to see if there was an increase in growth. And I found out that lactobacillus and bifidobacterium, I worked on two strains of bifidom, which is bifidum longum and bifidobacteria bifidum, and both were increased in case of with the Sprotone extract. So I have peeked into the gut microbiome aspect, and also right now we have a study which is happening in University of Manchester where we are seeing that insulin regulates the antimicrobial peptide release, which is a RECT3 beta. So if that project starts, I'll also be working with Sprotone to see if it in turn has any effect on the production of antimicrobial peptide as well. So I am looking into that aspect, but thank you for that.
Okay. Thank you.
Thank you for bringing to my knowledge one more molecule called Sprotone, which I can get from Amazon. 500 grams cost 365 rupees.
Exactly.
I want to know one question. Suppose I buy this half kg and keep it. What is the effect of storage? Effect of heat, light, humidity on this product? So by the time I finish the packet, am I getting the same value as I started it?
So we have done shelf life study and we have done shelf life study experiments, and the shelf life is 6 months. And even when I'm working in the university and here, I'm working on the product even after 6 months. So it's absolutely fine. We have already tested, because in order to get the FSSI license and all the other regulations, we need all these documentation. So it has all been done. It's completely safe to consume for 6 months. The expiry is 6 months. Thank you.
Thank you.
Any more questions?
Sir.
How did you arrive at this name Sprotone?
Oh, so the,
I was thinking as to why you chose the name Sprotone. Is there anything to do with Sprotone by any chance? Something which we
the
talked
brains behind the product is my father. So the naming process and all, it was completely in his hands. I have nothing to do with the name. It was his idea to name Sprotone. It's just basically sprouted cereals, so it's pro, and then since it has a homeostatic effect, Sprotone. I think that's the reason. I'm not really sure. I've never asked my dad that.
Actually, we have Dr. Sam here. He's an Ayurvedic physician, and this product is a 10-year effort, homegrown effort by Dr. Sam. He has tried various components, various quantities, and then came up with the product which is working. And Rinta has just borne the fruit of his research, and she is basking in the glory of Dr. Sam.
Exactly.
And one more thing is, actually the University of Manchester has expressed interest. This is a patented product. Sprotone is a patented product, and they have expressed interest to buy out the patent to the university. So very soon we will hear more and more about something which is homegrown and from Chengannur or Tiruvalla.
That's a hope.
Because every individual has got a particular microbiota.
Yes.
That where he is born in this country, this Kerala, that he should use the local indigenous food more than that of a westernized civilized food, which we are all now using it. So if you wanted to restore your gut flora, you have to use your indigenous food.
Yes.
Very soon, this will become a westernized product and come back to India. And then we'll start using it.
Yeah. Thank you.
So thank you so much, Rinta. That was a wonderful presentation. All the best for your future. Looking forward to a wonderful PhD and also path-breaking stuff. So next week we have a very, very interesting talk by our very own Principal and Senior Professor of Pediatrics, Girija Mohan ma'am. Listen to your patient. She is telling you the diagnosis. Precious pearls from ma'am's own clinical journey. It's going to be an exciting talk. So next week, same day, same time, same venue. Looking forward to having all of you attend to this session. Have a wonderful day. Thank you, BCMCH family.